All right, and we'll go ahead and get started here. So my name is Amy Hammond. I'm an RPSGT, a registered sleep technologist with patient safety and also the product manager for SatScreen. Today, we're going to be doing an in-depth dive into the SatScreen reports. Primarily, the goal today is to go through different cases and form a systematic way of reviewing your reports and kind of bring together what this information may help you do or what actionable items there are based on the information in the SatScreen report. So we'll go ahead and get started. Just as a disclaimer, all the examples herein are intended to be cases where the reference condition may be likely. These reports are intended for use as objective screening tool only and should not be used to diagnose sleep apnea or any disease or condition. And as an outline today, so we're going to go through some just very high level things in terms of what sleep disorder breathing is. Then we'll be going through our 4 primary dashboard indicators: the respiratory disturbance index, or the RDI, the baseline drift, the cycling time and cycling severity, as well as some example cases and report reading tips. We'll be looking at how to determine whether the study was valid. We'll also be looking at how to look at low risk upper airway resistance syndrome, obstructive sleep apnea, and also hypoventilation syndrome. Okay. So to start off with just some housekeeping, so sleep disorder breathing terminology. When we look at RDI in SatScreen, the RDI stands for Respiratory Disturbance Index. How we look at that is it's the hourly index of 2 to 4% desaturation associated with autonomic arousal, plus the number of greater than 4% desaturations. The primary differences with this from the AHI is that the AHI that you see in a sleep lab is used, only scores apnea and hypopnea events and requires direct or derived airflow signal. Because this is oximetry only, we don't carry any type of airflow signal, so we can't get a true AHI. Also, AHI typically does not include RERA events. And most of the time, even when you're getting an RDI from a sleep lab, RERA scoring is optional, so they may not have those events included. If you're asking what a RERA event is, again, that's a respiratory event-related arousal. So it's the number of minor oxygen desaturations associated with an autonomic arousal or heart rate rise or response. The ODI is the oxygen desaturation index, and this is the average number of greater than 4% oxygen desaturation per hour of sleep. In terms of sleep disorder breathing, there is a spectrum of sleep disorder breathing that patients may be experiencing, anything from excessive or disruptive snoring, known as primary snoring, to upper airway resistance syndrome, obstructive sleep apnea, central sleep apnea, Cheyne-Stokes respiration, and nocturnal hypoventilation. In terms of classifying apnea severity, there's some general guidelines. Typically, you're only looking at the RDI for classifying the apnea severity in terms of whether or not the patient is at risk for obstructive sleep apnea. So if there's anything that you take home today, understanding the RDI and how to take action based off of the RDI is the most important factor in determining whether or not your patient is at risk for obstructive sleep apnea. So with that in mind, a normal RDI is typically less than 5 events per hour. Mild is 5 to 14 with excessive daytime sleepiness or another comorbidity such as drug-resistant hypertension, history of heart attack or stroke, also diabetes and other comorbidities like that as well. Metabolic disease can be an indication or comorbidity of obstructive sleep apnea. So mild is 5 to 14 plus any of those symptoms. Moderate is an RDI of 15 to 30, and severe is typically considered 30 events per hour or more. Just because a patient has an RDI less than 5 doesn't necessarily mean that they don't have sleep disorder breathing. Sometimes they may have upper airway resistance syndrome, which is simply defined as a symptomatic patient who does not fulfill the criteria for OSA. And we'll talk about a few ways to get some hints towards that in the reports and considerations you should take a look at when determining upper airway resistance syndrome. So one of the things that sets our reports apart from other oximetry out on the market is our dashboard index. So you've got your green is good, red is risk. So the higher they are on those scales, typically the more at risk or more severe risk that patient has of having obstructive sleep apnea or sleep disorder breathing. So the first indicator we look at here is the RDI. So we have the 2 to 4% desaturations on the left side. We have our more severe events or major events known as the greater than 4% desaturations on the right side, and the culmination of the two in the middle for a total RDI here. So in this example here, we see 2 to 4% desats of 13, greater than 4% desat is 7, and then a total of 20 events per hour. The next indicator is the baseline saturation drift or the baseline saturation gradient. And what we're looking at here is the highest stable oxygen level during the night compared to the lowest. And that's independent of any type of overt apnea event. So this is the trend of oxygen levels over time throughout the night as the patient drifts off to sleep. It is normal to have some drifting when the patient falls asleep, just because breathing tends to become more lighter and relaxed. However, some patients, particularly those with complex sleep apnea or hypoventilation syndrome, will drift to a dangerously low level. So that's where we see this low value here showing up in the red section at 88.6. So the cycling time and cycling severity, those are indications of the ventilatory instability. So cycling time just tells us how unstable the patient's respiratory or ventilation was during the night, rather. It's an occurrence of one event typically triggering another, or just an inability to breathe. And now the cycling severity, we'll kind of touch on this a little bit more in just a moment, but it accounts for not only the depth of the desaturation, but also looks at the recovery between events and the duration of that event as well. So cycling severity accounts for frequency, duration, and depth of desaturations, as well as the recovery period in between events. Okay, and here we'll kind of dive into SpO2 cycling a little bit more. So this is something that you may have heard of before, but may not be very familiar with outside of our sleep shot reports. So essentially what cycling is cycling time is an indicator of ventilatory instability again. It's a recurrent pattern where one event triggers another and triggers another. Cycling severity is an indication of how severe the patient's apneas are, and where they're starting off at in terms of their oxygenation in the first place. So combined, they can tell you a little bit more about the type of sleep apnea the patient is having, and why that, we'll discuss too why that's important to you as maybe a dentist or a clinician in determining the best course of treatment moving forward. So also, you'll see on our reports in the raw data that we highlight the SpO2 and pulse cycling segment. So the cycling that's reported on the first page only is related to the SpO2 cycling or oxygen cycling, but you'll see those periods highlighted on the reports as well. So oftentimes you'll see that your pulse cycling and SpO2, both channels, you'll see some movement in both at the same time. That can be an indication of airway instability or the patient responding to an airway threat. So, however, it is possible they'll only have cycling occur in one channel. So sometimes you can have some variability too during REM sleep in the pulse channel, where your heart rate will become just naturally a little bit more variable. Okay, and we'll go ahead and get into the question of whether or not the study is valid. So a great place to start off when you're reviewing any of the reports is just to look at whether or not you have a valid study and have enough data to form some kind of conclusion from. So when we're determining that study validity, the things that we want to look for is the duration of the recording. So we recommend at least 4 hours of valid recording time, and the valid recording time is going to be displayed at the top of the report on the very right-hand side. And then if at minimum, you want to have at least 3 hours to make sure that all of the statistics are calculated. So the baseline drift, for example, needs at least 3 hours to be reported on. So you will see a flag on our report if the valid recording time is less than 3 hours. Just so that you know. Another thing to look at is if the error is greater than 10%, this doesn't necessarily mean that you have a bad test. What we want you to do in that situation, though, is it's very important to look at the raw data to see where that error occurs. And we'll kind of go into some examples of when you may want to do a repeat test versus just take that into consideration or not, when it's not a concern at all. So again, look at the duration of the recording. So we're looking for optimally 4 hours of valid recording. We're looking for error hopefully below 10%, or looking at the raw data if it is above 10% here. So with that, you may see some yellow error signals on our reports. It's just to allow you to determine whether or not you may want to repeat that study. So we'll go into the situations here that might be that might indicate a need for a repeat test. So this first example we have here is where you see a lot of intermittent drop-offs and blocking throughout the night. When you have something like this, typically what's occurring is pulse oximetry in general is very sensitive to movement and pressure. Many times it can be when the patient is up and walking around, moving their hand, maybe putting pressure on it in terms of moving around in bed. Or most often we see this type of error when the patient maybe has their hand underneath a pillow, or they're laying on it in some fashion, or holding it in a fist. Sounds unusual, but the best thing that we recommend for patients when you're handing out the oximeter at the beginning of the night is just to have them, just make them aware of tips for the best test. And we do have some of the suggestions on our website under our resources tab under SleepSat best practices. But in terms of getting the best study without error, you want to look at having a clean finger to test on, also making sure that the patient doesn't have any jewelry, and then that they're not lying on the hand or placing it underneath a pillow at night. And that'll usually help improve the viability of your test. These second types of error here may not necessarily be anything of substantial concern, as long as you have 4 hours of valid recording. So when we see error in a large block, such as in this first example here, that's often when the patient just maybe took off the oximeter to use the restroom. It may have come off the finger for some period during the night, and you're still getting enough a snapshot of sleep to make an informed opinion from, but you're just missing some sections of the data. We also see this quite often when for some reason either the patient leaves the oximeter on at the end of the night, or in the case of the Minolta, it doesn't turn off. So you might see something like this as well. So that can increase the amount of error percentage during the night, but you'll still likely be okay if there's 4 hours of valid recording. In this bottom example here, what we see is a very unusual or quick drop off with a lot of intermittent error signal in this situation here. So usually when we see something like this where it's not reading very well, we have some intermittent error, and you see something that's, say, a 20-minute, almost looks like a 20-minute desaturation. That's oftentimes when the patient is maybe moving around in bed or getting up and walking around, and the sensor detects some signal, but it's not quite good or bad enough to get an accurate recording there. So in these situations, if the rest of the test looks okay, your study may be okay. However, the baseline low and the SpO2 minimums may be impacted in these situations. So just keep that in mind if you decide to read from a test like that. Okay, and now we're going to get into some basic case examples here. So the first is low apnea risk. So overall, the things that we're looking for is a low overall RDI, less than 5, baseline saturation drift that's less than 6, and lowest saturation baseline at greater than 89%. We also want to see a low cycling time and a low cycling severity. And typically autonomic events are infrequent or they're mild in nature. So we have an example shown here of the raw data where you see very little movement in the SpO2 channel and very little activity in the pulse channel as well. So you typically will see, even in a fairly normal patient, some pulse activity or increases throughout the night, but they're relatively mild and infrequent in nature. So the next example here, apologize. Okay, and this is an example of the front page on this report. So what we see here is our RDI is low. Here it's 0 on this particular case. Our saturation baseline drift is less than 6 and also above that 89% threshold. And our cycling time and our cycling severity are low. And again, we see relatively little movement in the SpO2 channel and in the pulse channel. Now, in the case of upper airway resistance syndrome, you may also have an RDI below 5. However, there's going to be other things that you can look for that may give you an indication of whether or not the patient may have an airway issue. Some considerations when you're looking to treat upper airway resistance syndrome is, first of all, you want to look at the patient as a whole. So taking into account their symptoms, their clinical history and physical exam should indicate upper airway resistance syndrome. You also want to look at other causes of sleep fragmentation and make sure that they've been ruled out. It's something as simple as drinking too much caffeine or alcohol before going to bed, or even a disruptive bed partner who snores as well, or a pet or something in the bed can impact the quality of sleep. So you want to kind of rule those factors out before automatically assuming upper airway resistance syndrome is the problem in these patients. So, and often what we'll see as well is you might see minor fluctuations in the SpO2 channel associated with increased heart rate activity. And we'll take a look at some of that as well. Normally, the magnitude of the heart rate activity is going to be pretty substantial. But it can vary depending on the patient's age and overall health level. So it's less common for patients who are older or maybe have some heart disease to have a lot of pulse rate elasticity, whereas a young healthy patient may have a very substantial or drastic pulse rise, even in response to a very mild apneic event. So what we're going to be looking at for upper airway resistance on the reports is they're greater than 4% DSAT index, should be less than 5 per hour. You may have a low to mild overall RDI. You may see some increased re-res in there, but usually it'll be low to mild overall. And then we're looking for variable cycling time. So there may be some ventilatory instability, but this is relatively mild in nature. So variable cycling time, but low cycling severity on that. You're also going to want to look at your other parts of your clinical workup, make sure that they're suggestive of excessive daytime sleepiness. Snoring may or may not be present, especially in younger patients. They may just have some flow limitation or anatomical factors that may lead to you believing that. And then ruling out other sleep disorders as well. And here's an example of a patient with very little desaturation associated with a lot of autonomic activity, which makes us think that the threat of the airway is what's causing this issue. So oftentimes we'll see this in a very young or very healthy patient where their body is compensating for that airway threat by increasing their pulse rate very quickly. So they may have a very large sympathetic response to even that threat of obstruction. And that actually keeps their oxygenation at a stable level throughout the night. So what we're looking for in something like this is you'll see where the oxygen channel is fairly flat and unmoving. We also see that the pulse rate is pretty calm. As soon as we start seeing activity in this SpO2 or oxygen channel, we start to see a lot of drastic responses in the pulse rate channel here. So that can be an indicator in particularly younger, healthier patients that upper airway resistance syndrome may be playing a factor. So, and here's an example, front page, where we're looking at the RDI. So we've got the 2 to 4% desaturations associated with the autonomic arousal. That number here is 9. The greater than 4% DSATs is only 2, however. So OSA is unlikely, but does indicate some sort of sleep disorder breathing. We have a normal saturation baseline drift, a relatively high cycling time, but a relatively low cycling severity. Okay, and the next case that we're going to look at here is an example of obstructive sleep apnea associated with a low arousal threshold or mild loop gain. So typically when we're looking at these patients, what's happening is in some patients with milder forms of obstructive sleep apnea, they may be desaturating just a little bit, but their body overcompensates for that obstruction. So what they do is they start to have a desaturation and they overcompensate, take this big, deep compensatory breath, and that actually represses their respiratory drive again and causes them to go into one event after another. So this is where we see patients with low arousal threshold or milder forms of loop gain, perhaps in some situations too. So the things that we're looking for on the reports is going to be a mild to severe RDI, a moderate to high cycling time, meaning lots of ventilatory instability, but a relatively low to moderate cycling severity. So the severity of the events are relatively mild, but there's a lot of them occurring frequently throughout the night. And so a very simple tool that I use, a rule of thumb for high versus low, is there's a yellow tick mark on the cycling time and cycling severity index. Anything above that yellow tick mark is going to be pretty high or pretty severe. Anything below that is going to be in the mild to moderate range. So if, again, the cycling time is high and the cycling severity is low, and the patient has a respiratory disturbance index of 5 or more. This is likely indicating risk of sleep apnea associated with low arousal threshold. What happens is their ventilatory drive increases and causes arousal from sleep, and then destabilizes their breathing and sleep. So they get in this pattern of event after event. In these patients, research examining CPAP adherence found that non-obese patients with low arousal threshold are actually poor at adhering to CPAP long-term. So they may actually be better oral appliance candidates starting off. So again, these are usually your mild apnea patients with some ventilatory instability, but it's mild in nature. And we see an example here. Again, we're looking at the overall RDI is 16. We have 5 greater than 4% DSATs per hour, a normal saturation baseline, and a high cycling with a low cycling time with a low cycling severity. So relatively unstable, but mild in nature. The next example we're going to look at is obstructive sleep apnea with severe ventilatory instability or high loop gain. And these patients, what's happening is they're usually more severe in nature. They've had obstructive sleep apnea for a long time, and their threshold for arousing or awakening from sleep has been dulled over time. So they're only really arousing at kind of late stage end of life-saving sort of period here. So in these patients, sometimes you'll even see a milder RDI. So just because the RDI is only 10 per hour does not necessarily mean that the patient doesn't have a severe problem or isn't at risk of heart attack or stroke. The reason for that is some of these patients that have more severe apnea will stop breathing for, instead of several seconds, 10 or more seconds, they may be stopping breathing for, say, 60 to 90 seconds at a time. So they may have a lower RDI just based on the fact that they're having fewer but much longer events during that period. So we're looking at that first. And then the high cycling time and high cycling severity index will indicate severe ventilatory instability or complex obstructive sleep apnea. So in these patients, as you can see in our cycle here, they have that apnea hypopnea. They have a pretty severe or profound desaturation. They have that late stage life-saving arousal. They may wake up, they may not during recovery, and then kind of fall back into that pattern again and again. So, and here we see an example of the high cycling time and high cycling severity combined. This typically coincides with the risk of severe or complex sleep disorder breathing when you see this on a study. So a study actually examining OSA pathophysiology and the response to oral appliance therapy found that greater response to therapy occurred in patients with mild anatomic compromise and lower loop gain. So these patients that you see here with high cycling time and high cycling severity index usually have a more severe anatomic compromise than your patients in the first and second examples that we looked at. Normally PAP or a combination, or even sometimes a special BiPAP may be recommended for patients like this. So also introduction of any kind of sedatives or narcotics can increase the risk to the patient in these situations. So if you see a patient like this with a high RDI, high cycling time, and high cycling severity index, it's kind of a do not pass go, do not collect $500. Make sure that you get them into a sleep physician or for an assessment, further assessment, as soon as possible. And we see the example here. And as you can see, we have this kind of typical sawtooth pattern where the patient desaturates. You'll see kind of a long, slow slope down into the desaturation, and then a very quick rise once they arouse and get that muscle tension back and get back to breathing. The next example type we're going to take a look at here today is hypoventilation syndrome. So what this is sometimes patients will have a hypoventilation independent of any kind of sleep apnea. So they may have a normal RDI in some cases. The baseline drift in these patients is usually greater than 6, and the low saturation baseline, which is the most important value that we're looking at here, is going to be at or below 88%. So just because they have a normal RDI doesn't necessarily mean that they don't have sleep disorder breathing. Again, this saturation baseline drift is looking at their overall oxygenation independent of any kind of event. So, and we see here in this example where the patient is relatively stable in the low 90s, and they slowly drift down and stabilize at a different baseline over time. So, and again, here's an example of what that may look like. So our RDI is actually fairly normal, but we have a very pronounced baseline saturation drift and a low cycling time and low cycling severity index. I will say with the baseline drift, in some situations you may have air impacting that. If you do multiple nights and you only see a low saturation baseline drift in one of the nights, typically I would look at the raw data, see if there's a substantial shift in the baseline oxygenation that occurred immediately or right after some kind of error or movement. That can kind of indicate that maybe that's not a true measurement in those situations. That artifact may be playing into that. But if you see this throughout multiple tests, that's usually a better indicator that some hypoventilation or complex sleep apnea is occurring. And I will say that you can have hypoventilation coinciding with obstructive sleep apnea as well. So at this point, I'll just go ahead and open up the floor for questions, and then we'll take a look at some case reports as well. Okay, and if you'd like to ask a question, you can either, I believe, request to be unmuted, or you can also raise your hand. All right, we'll go ahead and move on. So what we'll do here is we'll just go ahead and look through some example cases from the more normal to some more severe types of cases. And the first one that we'll start off here with, I'll just go through basically how I would tend to read a report. So here's our example of a relatively normal case. The first thing that I'm going to do when I'm looking at a SatScreen report is look at the valid recording time on that. So in this situation here, we have a valid recording time of 5 hours and 17 minutes over here on the left. Again, we want to have at least 4 hours of valid recording. So 5 hours and 17 minutes is typically considered sufficient or enough to get all stages of sleep. Looking at the RDI in this case is 0, so no concerns there. We have a high saturation baseline. There's not much drift in that gradient there. And then we have a low cycling time and low cycling severity. This next section, the pattern-based report, typically I would just, in most cases, you don't really need to take much in-depth look at that. It's basically outputting what's on the dashboard in numerical form. The traditional report, there's a couple things here that I'll just make note of. The total time oxygen saturation was at or below 88% is going to be right here at the top of that traditional report section. In this case, it's 0. When that's above 5 minutes, though, that may indicate that the patient could be at risk for hypoventilation or eligible for nocturnal oxygen, supplemental oxygen. Here on this section, we have our ODI, just kind of some traditional basic values here. We have the ODI 4. We have received some requests for ODI 3 as well, which we'll be coming out with in Q1 of next year. So that will be reported here as well. We also have the average event duration, the longest events at or below 88%. We have the minimum SpO2, and then the average low SpO2. So that average low is taking into account the worst 10% of the night and average of that. It just gives a better sample when maybe you have an aberrant data point impacting that minimum SpO2. Also, we have some SAT ranges here. And if you're looking for decades, I do get this question quite often. If you're looking at time above 90 or time below 90, you can find that on the second page of our report down here in the percentage of total time SpO2 graph. So in green, it shows the percentage of total time spent in that decade. So in this example here, 100% of the night was spent at 90 or above. And then we'll also see on other examples that there's going to be a blue bar here as well that'll show the number of events in that SpO2 range. So this person had 100% of their night at 90 or above, and 0 events in that range. To go back up a little bit, we also now report on pulse rate data. So you're going to see the Autonomic Arousal Index. In younger, healthy patients, it's pretty common to see a higher Autonomic Arousal Index than on older patients. And young patients, in my experience, sometimes we'll see 15, maybe even more events per hour. Anything above 20 is typically fairly abnormal. We also have the mean, min, and max pulse rate range. Shows you the amount of sleep-related tachycardia and bradycardia. So bradycardia and tachycardia for sleep are a little bit different than wake. In sleep, the tachycardia is greater than 90 beats per minute, and bradycardia is at or below 50 beats per minute. So with bradycardia, it's not uncommon for many healthier, younger adults or athletes to have to be somewhat bradycardic or below 50 beats per minute. It's only when they're symptomatic in association with that's really a concern. The next 2 boxes we have here, those are primarily for our hospitals and things that we work with. But the first box here shows the risk for postoperative adverse events. So if you have a patient, if you're doing any kind of sedative dentistry, or if you have a patient that you know is going to be going in for any type of surgery soon, we give you their result versus the high risk reference range. So if their result is higher than, say, their ODI 4 events per hour is greater than 28.5, then that patient's going to be at a higher risk of some sort of post-operative adverse event. We do have the references at the bottom of the page for you as well if you want to look at the references for that. The second box here, that's primarily, again, for hospital providers. This is when an admission occurs for acute heart failure, their risk of rehospitalization. So basically, if the patient has sleep apnea, they've been hospitalized for acute heart failure, they're highly susceptible to rehospitalization in that situation. The next thing that we have here on the report is going to be just the overall SpO2 for the night. So the less ink we see on the page, typically the better. So most patients, if it's relatively flat and stable, that indicates obstructive sleep apnea is unlikely. And then on the subsequent pages, we also see not only SpO2, but also pulse. And if you have a Minolta, we'll look at artifact data and error signal as well. Error signal is in the sleep sat as well. So you'll see that highlighted here. And we'll notice in this particular study, you see a couple of just high pops here. That's actually artifacts that we're typically looking at. When you see this very, very quick, it's called pulse channel popping, where you see a quick increase over a matter of a second to 120 and back down or something close to that. That's typically not physiologically possible. Whereas the smaller events here are more likely to be the actual arousals. And you can kind of see that if you need to take a closer look at that, and you'll see that waveform or that slope on real events versus there being really no slope on those pulse channel artifacts. So the next one I'm going to take a look at is maybe an autonomic event. So this might be a case where upper airway resistance syndrome may be suspected. And again, with any kind of upper airway resistance, you want to take a look at not only their sleep sat report, but also their whole clinical history, their physical workup as well. Again, we're going to look at our valid recording time. So in this situation, we have 6 hours and 43 minutes. Our RDI is low. It's they only have 2 to 4% DSAT per hour. Saturation baseline drift is good, and then pretty much no cycling time or cycling severity, so no ventilatory instability going on here. Everything we see here is kind of in the same normal range. Autonomic arousals, we have an index of 1 per hour. Okay. Our SpO2, everything is in the normal range here as well. But when we take a look at their raw data in this situation, we see, again, what we're looking for here is when we have some moments of activity in the SpO2 channel, we see a lot of exaggerated pulse rate activity here for this patient. And when it's relatively stable, so for example, in this, it's not allowing me to select that, I apologize. In this area right here, we see in their heart rate channel that it's relatively stable in both the pulse and the heart rate. Once we start to see some activity in the SpO2 channel, we do see a lot of activity in that pulse channel. So that can be, it's not always, but can be an indication of upper airway resistance syndrome. You see this oftentimes in very young individuals, youth and adolescents, when taking a look at their studies. So what they're doing is their heart or their autonomic nervous system is making up for that threat to the airway. Okay, and just skip through here, just trying to be mindful of time. I do want to get to a kind of special case where you may see in some cases a patient may have a REM or a positional dependency where their overall RDI isn't very high. However, they may have a lot of activity during certain periods of the night. So in this situation, we have a valid recording time of 4 hours and 53 minutes. So it's above that 4-hour baseline that we're looking for. Our RDI is 6 overall, so 2 to 4% DSATs per hour. 4 of those major events are greater than 4% DSATs per hour. High saturation baseline drift, And relatively mild to moderate cycling time, mild to moderate ventilatory instability associated with mild severity. However, when we take a look at the SpO2 data, this is what kind of gives us an indication of maybe REM sleep. So there's a few things that can indicate REM-dependent sleep apnea. And REM-dependent sleep apnea is where the patient may only have sleep apnea during REM sleep. Oftentimes what we're looking at here is for a relatively normal night otherwise, with periods every 60 to 90 minutes of sleep disorder breathing that usually become longer and longer throughout the night. So we see here the patient has their first cycle of sleep disorder breathing, this activity right here, right around 70 minutes into the study. Then again, about 70 more minutes, a little bit longer period through here. And then we see again, another final period here at the end of the night. So sometimes that can indicate REM, what they call REM-dependent sleep apnea. So, and here in their percentage of total time, their SpO2 graph, they spent 100% of the time in that 90% range. They had one event that dipped down into the 80 to 89% range. On this right side here, we see the same data outputted for the pulse channel in terms of the time spent with their pulse within a certain range and the number of events or autonomic arousals that occurred in that range. And then when we take a look at the raw data here, this is just a more zoomed in view of that raw data. Okay. And then this example here may be a positional dependency. This one is less than ideal when we take a look at the valid recording time, so 3 hours and 43 minutes. We want to have typically want to have 4, but minimum of 3 hours. Our RDI is abnormal, so we have 2 to 4% BSAT per hour and 19 greater than 4% or more severe events per hour. Saturation baseline drift is in normal limits. Our cycling time is high and our cycling severity is high as well. So this indicates a lot of ventilatory instability and usually a more complex type of sleep apnea. So, and as we can see here, this patient in the SpO2 channel, normally with positional dependency, we'll see something like this where the patient may have very, very severe events that all of a sudden stop or somewhat normalize when they move or make a positional change, and may restart if that patient moves back to that position again. So oftentimes when a patient lays on their back, they may have a much more difficult time breathing, and it may lead to that positional dependent sleep apnea. This is not in all cases, but these are some things that can impact the overall RDI, or actually underestimate the overall RDI for the patient compared to whether or not they're in REM sleep versus regular, whether or not they're having OSA versus not. Okay. And I think that covers that. The last thing I wanted to touch point on here today is I often get questions about titrations or strategies for titrating. So oftentimes when you're titrating a patient, basically you want to get them into the green. So there's a couple of different approaches that I've seen practices take, and maybe we have some people here that can open that up for discussion. But oftentimes they'll either do something where they'll do sort of a fast track titration and may have the patient take the pulse oximeter home, where the pulse oximeter night after night at different settings on the oral appliance, and then choose the best setting based off of the data that they get back from that. In other situations, usually with that, I would recommend taking a baseline the first night just to be able to compare apples to apples, and then testing at 1 setting, 2 settings, 3 settings, setting 4, and finding that sweet point, then slowly working the patient into being able to tolerate that on a normal night. Again, sometimes patients don't sleep very well in those situations just because you are moving the jaw forward further faster than would be normal. So another approach that we do see as well is to subjectively titrate the patient with the oral appliance. So make sure that any kind of snoring is gone, that they're feeling better, more rested, and at that point, trying to confirm with pulse oximetry. So oftentimes what we'll see is once a patient is subjectively titrated, they may need a little bit more tweaking in order to fully feel good or stable after that, or need a little bit more adjustment to get rid of the rest of their events. And in these situations as well, so in this example, we may see when you're titrating the patient, sometimes you'll see the greater than 4% defect start to decrease and actually see a temporary rise in the minor events per hour. So ultimately, your goal during titration is to get the overall RDI at or below 5 events per hour. But if you can't do that, to at least get the greater than 4% desaturations under 5 events per hour. That's going to be similar to the AHI that they would score in a sleep lab. So, and I can pull up case examples or anything like that, but I think I'm just going to open it up to questions, see if anybody needs, has anything that they'd like to cover specifically, or if any specific questions that you have. Okay. Okay, I don't see any particular questions. Let me just see if I can pull up. We do have a couple of more minutes, so I'll see if I can pull up that couple examples of titrations or a multi-night report here. And we do have a new feature in our online or SAT cloud that allows you to look at your reports over time. So you can access that at any time by clicking on the SAT cloud link in your Connection Center app. You can also see it if you go to patientsafetyinc.com or sleepsat.com and click on the login there directly as well. Okay. Okay, I see a couple of, okay, and Dr. Shupel asked, will this be recorded for future viewing? Yes, it will be as well. So while we'll just go ahead and get wrapped up here. So if you haven't seen this yet, I do want to share one of our multi-night reports here for you. This is a great tool to use as you're beginning to titrate a patient. This example here is of an actual patient titration. So we can see here the study dates. This particular one took quite some time. As you can see, the patient started off with a pretty severe RDI, however, and actually had some minor increase in the RDI. But what we'll find when we look at the entire report, and let me just see if I can adjust that, is although the RDI increased on the second night, when we look at the cycling severity, the severity of the events that the patient was having drastically decreased here. So we do see that even though they had a slight increase in the RDI, the severity of those events were far less severe than at that first night. And again, that kind of goes back to patients with more severe apnea. Sometimes they will have longer pauses in breathing. It may actually have a lower RDI as a result of that. So we do see a temporary rise in the RDI here, but our cycling severity kind of tells us that we're going in the right direction. Although, you know, they're having more events, they're less severe in nature. We also see an overall trend in our oxygen levels going up over time as well. And the ventilatory instability starting to decrease over time. Now, sometimes that ventilatory instability will take a while to stabilize. If it is loop gain, there are medications that can help with loop gain as well, if that's the cause of that. But again, the SatScreen reports are meant to be a very accurate tool to help you screen and titrate. You do still want to have the patient go for a diagnosis, particularly in situations where you suspect obstructive sleep apnea. So that's an example of the multi-night report. You can find that on our website, sleepsat.com. You can pull that up for any of your patients that have done more than one test. The dashboard is also available interactively on that website as well. And to take a couple extra moments, we are excited. We're getting ready to launch a beta connection center application that's going to integrate that web portal a little bit better for you than our current connection center does. So what you'll see in this beta app that's coming out, actually it will be released next week. You'll see that the patients and reports are available right here through your connection center screen. So there's no more having to know about our web portal to view that. You can create your reports, you can view your patients. Sorry, I believe I'm not logged in right now, but you can do that all right here online with us as well. So, and once you're logged in, I'll show you your cases. And I believe I may be using up quite a bit of my bandwidth here with Zoom, so it's just taking a little while to load. But yep, you have that available as well. Okay, there we go. So this particular patient has quite a few reports. You can see that happening here as well. Also, if you're not familiar with it, or if you have staff that are doing reporting for you, we do have a new risk-based alerts function where it will identify any type of report that's outside of normal limits. So as you can see here, you can sort by RDI, their baseline drift, whether it's normal or abnormal, cycling time, if they're at post-op risk, or if they have an insufficient amount of valid recording time as well. You can see that here. That'll be flagged for you too. All right, I believe that wraps everything up today. I want to thank you for your time. If you have any other questions, please feel free to post them in the chat or raise your hand and be happy to answer that. But again, thank you for your time, and please let us know. We'll send out a copy of the recording at the end of today, and let us know what we can do in order to improve this as well. So, all right. Okay, thank you all. Have a great day.